Okay, students, apologies for yet another wonderful recording. Um, so this recording is for week 8, chapter 6 and the rest of 6 and chapter 7. And then at the end of the recording, I have decided, since I'm not there with you guys, I'm going to kind of review what your focus should be for study for the exam this weekend. So human sexuality and fertility. So here are your learning outcomes. Um, oh shoot. Um, Let me get big screen. All right, so please review these. And so we're just going to do a really quick, hopefully a really quick lecture here on chapter 6. So for women who are having an abortion or problems with contraception or conception even, one of the huge things that we do is not only guidance, but the emotional support and our therapeutic communication. So just being very careful with what we say and how we say it when it comes to people who are having problems with these issues. Okay. So anyways, clinical termination of pregnancy. So any pregnancy that ends before the age of viability, which depending on what resource you're using is anywhere from 20 to 24 weeks. So in that gray area, up to 24 weeks, there will be a conversation with the perinatologist, neonatologist, and the patients about, is this baby viable at 23 weeks or is this baby viable at 24 weeks? We did have a patient that was 26-ish weeks, I think, recently, and they were determining this baby would not live just based on the health of the pregnancy, the testing that they had done on the fetus. And it didn't. After several days, the baby did pass. But the age of viability can be somewhat of a moving target. So you'll see 20 to 24 weeks as possibilities for age of viability. So anyways, if the pregnancy ends before 20 to 24 weeks, then it's an abortion. Whether it's a spontaneous miscarriage or a spontaneous abortion, or whether it's elective or a therapeutic abortion, okay? Elective and therapeutic are kind of somewhat the same in that, they're opting to have an abortion. But the therapeutic is would be considered for, they would term it therapeutic for a patient who had did some genetic testing on the pregnancy and determined that the baby had lots of anomalies and which may be incompatible with life, or if the pregnancy, carrying the pregnancy would be too risky for the mother's health. Okay. So when we're doing some type of elective or therapeutic abortion, if the pregnancy is between 5 to 7 weeks, we'll do a manual extraction or a menstrual extraction, an endometrial aspiration, where they insert a small tube into the uterus and aspirate the contents of the pregnancy. Between 7 and 9 weeks, they usually use a medication to cause a termination of pregnancy, and cytotec is maybe that methotrexate. I think is the one that I've not really done this in my practice. Sometimes this is done on most of the time this is done on an outpatient basis. So I'm not usually managing these patients from 6 to 9 weeks that are having some sort of medication assisted abortion. Now they may do these at clinics, but these medication assisted abortions, but oftentimes they'll give the medication to the patient. The patient will go home and take the medication. Then somewhere between 10 and 12 weeks, they can do the vacuum aspiration with laminaria. And then if the patient is beyond 12 weeks in their second trimester, they have to dilate the cervix and then do an evacuation procedure with lamaria or side attack. So after the procedure or after the medication is taken, this person will have some cramping. They will have some bleeding. That's all normal. We can give them some NSAIDs for the cramping. And as long as what we feel is normal post-delivery bleeding for this gestation, she might bleed a couple of weeks after the termination. But if the bleeding seems to be more than, a heavy period, if there seems to be an infection, foul smelling vaginal discharge, a lot of abdominal pain, then those are things she needs to report. Now, as far as incomplete abortions, that's where we don't get all the products. If we're doing performing an abortive procedure, or if the patient is spontaneously aborting and she doesn't abort all the contents of the pregnancy, then she could be at risk for hemorrhage and infection. And there could be abdominal organ trauma. We could cause an embolism. Asherman syndrome is where they have the uterus ends up with a lot of adhesions and scarring, which would probably cause a lot of problems for the woman during her normal menses and with future pregnancies. Post-abortal syndrome, severe abdominal cramping and pain, and then blood clots, passing a lot of blood clots, post-abortal syndrome. So those need to be reported and treated. All these things are pretty rare. Abortion procedures, if they're done in approved clinics by, experienced and good doctors, then these can be pretty safe procedures. So we're just going to be supporting these women, letting them know about their signs and symptoms, the complications they should be watching for, but providing psychological and emotional support is really important for these people, because even if they elect to have an abortion, if it's I want to have an abortion because I don't want to be pregnant, they may not have any emotional issues related to this for quite a while, but then maybe sometime in their future, when their life situation has changed, then they might start having it's not a post-traumatic stress syndrome type thing, but then this is when they might start dealing with their psyche when it relates to the abortion they had years previously. So we might be doing some supportive care for women who are years post-abortion. And then women who have therapeutic abortions, they can have some immediate need for psychological support. All right, infertility. So when we have patients coming in for infertility, a couple things we need to know. The difference between sterility and infertility. So sterility is an absolute factor. I mean, absolutely they cannot reproduce. Okay, so we have a sperm and ovum, of course, have to meet. The sperm have to be viable. The egg has to be a normal egg. And the lining of the uterus has to support the pregnancy. So there is an absolute factor with one of those items that makes them not able to reproduce. So they would have a permanent sterility problem. Infertility, so we would diagnose a person with infertility who has not conceived after 12 months of active attempts. So usually these people, have trouble getting pregnant. And so they start, doing some fertility awareness things to try to find out when their fertile time is and try to conceive. And so they're diagnosed with infertility when they've done that for 12 months and have not been successful. And so then they do further testing and then decide if they're sterile or not. So our role in patients with fertility issues, of course, we need to evaluate, we need to educate them. We need to educate them about all the fertility awareness things that they can do, and educate them on the timing of intercourse, when in the menstrual uterine cycle they should be having intercourse to try to become pregnant. We can teach them about the signs of ovulation, when's the best time to have intercourse, different positionings that the woman can do to retain the sperm after intercourse, and then, counseling services, because, these people might be having a lot of distress and emotional problems because of their difficulty conceiving. So after we've done all that education and they've been through their 12 months of trying to conceive, we're going to be doing some more thorough workup. So, of course, we're going to do an in-depth medical history of both parents and their family history. We want to know about their lifestyle patterns and their work, where they work, and all those kind of things. Anything that we would think that might affect their ability to conceive. So we're doing this very in-depth history. Their infertility workup would be doing ovarian function tests, testing the cervical mucosa, testing the sperm, looking at the fallopian tubes, looking at the actual uterus, general conditions of the pelvis and pelvic organs, the pelvic structure, the woman's BMI. There's several different labs and diagnostic tests we can do, and you can look at those. They're in the table 6-2 on page 179. I don't want to read those to you, but please look over those and kind of be aware of the different kind of diagnostics that we can do. So for the woman, we're definitely going to be looking at her thyroid function. We're going to be doing glucose tolerance tests, serum prolactin levels, doing a lot of hormone tests, doing a lot of ultrasounds, and possibly even doing biopsies of the actual uterus, the endometrial tissues. The hysterosalpingography. So just the radiology test, they infuse a dye so that they can better visualize all the structures of the uterus and the fallopian tubes. And then the laparoscopy is where they do a puncture in the abdomen, and they go in with the little camera and they can visualize the structures that way as well. For the male, we're going to do a semen analysis to assess for the quality and quantity of sperm. They might have good quality sperm, but they don't have the quantity, or they might have the quantity but not have very good quality, or then it could be both. So we're just going to see where he stands as far as his semen is concerned. We'll also do hormone endocrine function tests on the gentleman. They do a postcoital test, so they assess the cervical mucus and the sperm and the ability of the sperm to penetrate through the cervix. So they can do that kind of test, and then they can do ultrasounds, they can do biopsies of the testes, they can do all kinds of sperm penetration type of tests. So there's a lot of testing that goes on. And with each test, sometimes they go through each test and, it's kind of like a hierarchy of tests. Well, let's test this first before we test this, before we test this, before we test this. And sometimes that can be a very emotional roller coaster for your peeps. So if we find that they have an infertility issue, there are medications that we can give to help according to what the problem is that we've determined. So if we've determined that it's an ovulation problem, we can give medications that induce ovulation. So it would be some sort of follicle stimulating hormone, luteinizing hormone. If you remember from the last lecture, those hormones help grow and develop that follicle that has that the ovum in it. And so those hormones help that to grow and develop, and then the luteinizing hormone is what is responsible for the actual ovulation, the releasing of the egg. So they might be getting supplements for that. They might get supplements to help their uterus prepare for implantation. Maybe it's a uterine problem. And then, is she getting pregnant but not able to keep the pregnancy? So they might want to find out what's going on there. Or if they're actually doing some sort of external fertilization or, those kind of procedures, insemination type of procedures. So you can see page 6-9 on page 180 for more information on that. Now, any type of medications or supplements or hormones or whatever that we do to help with ovulation, we definitely run the risk of multiple gestation. We can cause an ovarian hyperstimulation, and that could actually cause a problem for the woman. So her ovaries would enlarge. They may get ascites or fluid build up. She could have pain, develop pleural effusions, and all kinds of things. So these are the risk factors, some of the risk factors of using medications for infertility. Now, there are a lot of surgical options if we find that there is something anatomically we can correct. We can do, correct obstructions of fallopian tubes, ablation of endometriosis, or if she has adhesions, we can remove those adhesions. And then we can do another option, if this is it, we can do a therapeutic insemination, where we prepare the sperm and place it in the cervix or in the uterus to help with fertilization. There's all these other assistive reproductive technologies. I do just want you to kind of identify each one, be able to identify each one in basic terms. Don't get in depth with your study on these. I hate to say it, but these will not be on the exam. But I do want you to have some sort of memory of these different possible reproductive therapy options. Okay. Now, fertility treatment is super expensive for the couple. Some people, they use their life savings or get a second mortgage on the home, or I don't know, they do all kinds of crazy stuff to financially be able to afford this. And then if they're using any of those reproductive therapies, especially if they're harvesting eggs from someone else, or if they are using sperm from someone else. There's the issue of donor, get where they're getting those from, the confidentiality of those people. So some people may do not want to have any type of be able to be identified at all. Some will at least give general physical characteristics of themselves. Some may provide a really thorough family background. So it just kind of depends. And then again, like there's ongoing education and counseling for this couple, because this could take years and years and years to help these people, and then it may end up that nothing ever happens. So again, there's a lot of emotional stress. Each time they try a different therapy, it may or may not work. They do have that sense of loss and grief, like they've lost a pregnancy, or they've lost the hope that they had just had from these interventions possibly working. And then we may affect the couple's sexual health with each other. So where sex with each other becomes a job now, and it's no longer intimate, and there could be problems in the marriage related to that. So there's just a whole slew of things we need to do for this couple to help them. So now when we're working with people, fertility treatments, we do set up healthy lifestyles. Like this is a major thing that's going on, and to be successful, not only do they need to follow these treatments that we're giving them, but they also need to live a healthy lifestyle, because if they're not living a healthy lifestyle and doing things that they need to do, and they spend all this money on this fertility treatment, then it's just going to be a waste of money. So we really try to set them up with the best possible outcomes. So we help them with their lifestyle choices, like a physical activity program, good nutrition, stress management techniques, adequate rest. We may use holistic or complementary therapies. And then there's all kinds of herbal supplements that patients can take that will support or enhance or set them up for possible conception and implantation of the pregnancy. But we need to, so you can look on this page 184 for a list of herbs that would be really bad to suggest. So we just need to be really careful. We need to find out, like, if these people have heard stories about using this or using that, and if they are using these things, we really need to find out, because they could be getting wrong information and they could jeopardize their chances of conception and all that kind of stuff. So we just need to know what's going on. And then if they cannot conceive after everything has been done, we can, suggest to them other options, like using a surrogate, a gestational surrogate, or, someone to carry the pregnancy for them, whether it's their own, if it's the couple's sperm and eggs, or if it's the surrogate's eggs, or if it's donor, both egg and sperm, like however that falls out. And yes, there's all kinds of ethical and legal things to consider with that. We could suggest and support and give them information about adoption, or if they're against these things and we cannot be successful in having them conceive, then a child-free life may be what this couple is looking at, and they may need some support in accepting that, or whatever. So lots of things to consider when it comes to fertility. I've already talked about the nurse's role here, so we just need to make sure we're doing a lot to support this family. All right, so that's the last of chapter 6. Let me look at chapter 7 here. Let's look at chapter 7 here real quick. Also, that's a lot of slides. So I just had someone walk in here. So I'm going to post this sorry, I'm going to post this recording, and I'm going to come back and record chapter 7 in a little bit.